Hello and welcome to this short video covering all the primary care relevant aspects of the modern management of hypertension. I'm Yassir Javaid, a GP with a specialist interest in cardiology and also a clinical lead in my local region of Northamptonshire in the UK. And I'm joined today by a fantastic secondary care expert, a good friend and one of the leading cardiologists in the UK, Dr. Ravi Assomull. And together we are aiming to offer some very clear practical tips and guidance that can be used in everyday clinical practice. Welcome, Ravi.
Thank you very much, Yassir. Delighted to be involved. Thank you for inviting me.
Hypertension is clearly one of the most potent independent cardiovascular risk factors. We know the risk of dying from cardiovascular disease, your cardiovascular mortality, increases almost exponentially as your blood pressure increases from a normal level. We see this almost doubling of cardiovascular mortality for every 20 millimeters of mercury increases in systolic blood pressure. Ravi, hypertension must be a common denominator in many of your patients. Please, can you reinforce just how devastating hypertension is as a driver for cardiovascular disease?
Absolutely. It underpins a variety of cardiac conditions that you will see in primary care, and we unfortunately see in secondary care when it progresses and a patient decompensates, and namely coronary artery disease, atrial fibrillation, heart failure, hypertension. If you look back at the history, hypertension is the common denominator, often undiagnosed or undertreated. So it's critical to make that diagnosis, critical to use the plethora of treatments now available to get blood pressure under control. So yes, hypertension is very much the common denominator for a wide array of cardiovascular conditions.
Right. So and I think we mustn't also forget that hypertension is also associated with target organ damage outside of the cardiovascular system. For instance, the eyes and the kidneys is actually, after diabetes, the second commonest cause of end-stage kidney disease. And we know now it's also a potent driver for accelerated dementia. So really a very important condition to identify early and manage optimally in our patients. But really, where hypertension is associated with the most devastation is in accelerating the atherosclerotic process. And atherosclerotic cardiovascular disease remains the single biggest global killer, responsible for about 25% of all deaths in the UK, many of which are premature and tragically preventable. But therein lies the opportunity. Ravi, atherosclerosis starts at quite a young age, doesn't it? I mean, could you even argue it's part of the normal aging process?
Absolutely. Kind of from your late teens onwards, you start developing what we'll refer to as fatty streaks. And it's a given understanding that most adults, the vast majority of adults, will have a degree of minor atherosclerosis, certainly nothing that will be detectable clinically by symptoms. But in the era of CT coronary angiography, where we see more, we have imaging of plaque, we're seeing more and more of it, and I'm never surprised at how young people appear to develop plaque nowadays.
Yeah, so I think it's unrealistic to think we can prevent atherosclerosis. What is realistic is to aim to slow the progression, and this will give significant increased quantity and quality of life to our patients. Clearly, there are risk factors that we can't do anything about, the non-modifiable risk factors, advancing age, sex, genetics, and ethnicity. And sadly, Ravi, we have both been blessed with most of these. But what is within our gift to address in our patients are the modifiable cardiovascular risk factors: lifestyle, central obesity, lipids. Chronic kidney disease is now known to be a significant atherosclerotic driver. But what I wanted to highlight are these two modifiable risk factors in particular: diabetes and hypertension. Ravi, we've already touched upon how devastating hypertension is as an independent cardiovascular risk factor, but when combined with diabetes, give us a flavor for how hugely increased the risk is sort of magnified.
Yeah, absolutely. I think it's the perfect storm. I'd refer to it as. You have diabetes and hypertension, both are sadly underpinned by Western lifestyles. And really, the issue is hypertension becomes far harder to treat with diabetes. You often can get issues with kidney disease, which in itself makes hypertension more difficult. And we also know that, sadly, despite hypertension being more difficult to treat in patients with diabetes, you actually have to treat to a lower target. So it's more demanding. So really a combination. These are the kind of patients where I'm often scratching my head, worrying about how to get them to target, knowing the target is actually far more stringent and, dare I say, lower than patients who are non-diabetic.
Great. Well, now let's look at what current guidelines say about the management of hypertension. And we'll start off with our national guidelines in England, the NICE guidelines. In terms of establishing a diagnosis, it's very clear that the clinic blood pressure readings alone should not be used to establish a diagnosis. Ravi, should it now be standard practice to use either ambulatory blood pressure monitoring or home blood pressure monitoring to diagnose hypertension? And if so, why?
Well, absolutely. I mean, it's the why is we know that 10 to 15%, or closer to 15 to 20% of people who have a high blood pressure reading in a clinic setting will actually have a lower and potentially normal blood pressure reading at home or on an ambulatory blood pressure monitor. And equally worrying, if not more worrying, is that often there are 10 to 15% of patients who will have completely normal blood pressure readings in a clinic setting, but actually at home it's higher. And in some way, those patients have a far worse outcome. That's called masked hypertension. So for me, ambulatory blood pressure monitor and home blood pressure monitoring in these days where resources potentially aren't available to provide ambulatory monitors to everyone is critical. You cannot make the diagnosis of hypertension using clinic blood pressure readings alone.
Well, that's very clear. And we'll discuss the potential virtues of automated ambulatory 24-hour blood pressure monitors over home blood pressure monitoring a little later. But it is important to note that the guidelines state that ideally we should be using at least 14 readings averaged out to gauge someone's blood pressure. So in practical terms, I ask patients when they're monitoring blood pressure at home to get a week's worth of readings, taking their blood pressure twice a day, with each of these readings being the best of 2 recordings taken a minute apart. And perhaps once blood pressure is well controlled, repeating this, Ravi, is every 6 months or so once blood pressure is controlled. Is that reasonable? We don't want patients getting obsessed with having to take their blood pressure every day of the year, do we?
Yeah, no, I think 6 months is a very reasonable way. I mean, hopefully things shouldn't change dramatically, but if things do start to creep, you will notice it within 6 months. I think 6 months is absolutely ideal.
Great. There is, of course, one significant advantage of automated 24-hour blood pressure monitors, and that is the fact that they can record blood pressure during sleep. Ravi, what is the clinical relevance of nocturnal blood pressure readings?
So the treatments are kind of validated on diurnal readings, but actually the nocturnal readings provide us a really good with good information about whether patients' blood pressures dip at night. So a normal physiological response in a patient with a nice compliant vascular system would be that you'd expect the blood pressure to dip at night. In those patients who are non-dippers, i.e. the blood pressure doesn't drop, that suggests that the vascular system has potentially become stiffer. And even if the blood pressure is within normal limits, that kind of non-dipping gives you a clue that these patients are at higher risk in the future. Also, in certain patients with secondary causes, you'll lose that dipping blood pressure, but that's very much a niche and a tiny proportion of patients.
Yeah, and of course, 24-hour blood pressure monitoring is often not readily available to us in primary care. So we would like to stress that home blood pressure readings, as long as they're done appropriately and frequently, are an accurate and acceptable way of diagnosing hypertension and ongoing monitoring of blood pressure control, far superior than relying on ad hoc clinic blood pressure readings, which, as Ravi has reinforced, really should be a practice of the past. Now, the SPRINT trial presented in 2015 was one of the most important hypertension trials in recent times and looked to answer that age-old question of what blood pressure target to aim for. Many of us have been very comfortable aiming for systolic blood pressures just under 140 millimeters of mercury. So this trial, in a high-risk population, though it did exclude patients with diabetes and stroke, where, to be frank, we already know more intensive blood pressure control is beneficial. Well, this trial compared standard blood pressure control of just under 140 millimeters of mercury versus intensive blood pressure control of just under 120 millimeters of mercury. The primary endpoint was to look at the rate of major adverse cardiovascular events, including acute coronary syndrome, stroke, heart failure, and cardiovascular death. Essentially, all the bad things that can happen to you from a cardiovascular perspective. And the results, Ravi, were conclusive, weren't they, in terms of showing significant incremental benefit for the patients more intensively treated. Was this a surprise to you? And should it now change routine clinical practice?
I wouldn't say it was a complete surprise, but I have to say the magnitude of kind of improvement in terms of outcomes was a surprise. I did expect things to be better, but not so significantly. should it change management? Well, there is a difference in guidelines between the Americans and the European guidelines. And dare I say, I'm inclined to agree with the European guidelines, which take a more modest approach. The one thing is these targets were on the SPRINT trial were based on ambulatory blood pressure monitor recordings, which traditionally are lower than the clinic recordings that were used in the older trial. So that has to be factored in. Also, the trial did show that you're more likely to get side effects in the intensive treatment related to hypotension. So I think, to be honest, the European targets of 135/85 are a fair balance between getting your blood pressure low and minimizing the chance of side effects and subsequent discontinuation of the medications.
Well, that's a great point. And certainly national and international guidelines, they are generally becoming more sort of stringent in terms of advocating more aggressive blood pressure targets. I mean, our NICE guidelines in England recommend a default blood pressure target on ambulatory or home readings of 135/85. The European Society of Cardiology guidelines, I think arguably the most prestigious guidance we have in cardiology, now clearly recommend a default blood pressure in patients under 65 of less than 130/80. But of course, Ravi, as you alluded to, we must factor in the patient sitting in front of us, and perhaps not just their age, but more importantly, factor in frailty when we decide on individual blood pressure targets. Is that what you do in clinical practice?
Absolutely. I think one size never fits all. So there will be patients who are frail, who have labile blood pressures, and if you try to aim for this kind of this specific target, you will land up causing more harm than good. So for those patients, you have to accept, fine, blood pressure isn't perfectly controlled, but you've got it as good as you can. What you don't want to do is create a hypotensive episode resulting in a fall and a broken hip.
Yeah, fantastic. So I try and keep it very simple. I aim for sort of less than 130/80 as a default, and sort of rein it in when I genuinely feel a patient may fall over and break their hip, as Ravi says. So a clear message, though, to try and be perhaps a little more aggressive with blood pressure control than we have in the past. And in medicine, you don't get something for nothing. And Ravi has already reinforced that the SPRINT trial did demonstrate, albeit a relatively small absolute price to pay in terms of achieving more intensive blood pressure control. Not surprisingly, we saw small increases in risks of hypertension, electrolyte disturbance, and acute kidney injury. Again, reinforcing the importance of what Ravi mentioned about factoring in age, frailty, and comorbidities, as well as, of course, we must reinforce things like sick day rules for drugs like ACE inhibitors and angiotensin receptor blockers. There are a lot of recognized risk factors for developing essential hypertension. Again, genetics do play a big role, and we often see hypertension sort of running in families. But Ravi, can you tell us specifically about the impact of obesity, particularly visceral or abdominal obesity, on the likelihood of developing cardiovascular risk factors in cardiovascular disease? This is becoming a hugely critical risk factor, arguably more potent, is it, than just having a high BMI?
Absolutely. We know patients with completely normal BMIs who have abdominal obesity are at greater risk than patients whose BMIs are elevated. Now, if you look at most personal trainers, they've got high BMIs, but they've got very little visceral fat. So actually, weighing scales and kind of measuring tapes to measure height in clinic is useful. What's far more useful is a measuring tape to measure abdominal circumference. And there are now scans available to actually quantify the amount of visceral fat, which haven't quite made its way into kind of day-to-day practice in terms of resource and kind of cost effectiveness, but it wouldn't surprise me in decades to come whether that becomes part of the standard assessment.
Yeah, I mean, this fat around your major organs, your liver, pancreas, kidneys, and heart is associated not just with insulin resistance, but also we know it induces a pro-inflammatory state, accelerating atherosclerosis, as well as causing type 2 diabetes, dyslipidemia, and is strongly associated with hypertension. So, Ravi, you specifically, I know, advise patients on how to address visceral obesity, and I guess this should become, hopefully, a routine part of counselling and management, and move away from just focusing on BMI, because we certainly see patients of certain ethnicities having an apparently normal BMI, but big waists. A lot of us advise patients to cut their salt intake, which is a class 1A recommendation within the ESC guidance. Interestingly, the blood pressure lowering effect of salt reduction is more pronounced in Black people, older patients, and patients with diabetes, metabolic syndrome, or CKD. We mustn't also forget about alcohol intake and lack of exercise as drivers for hypertension. I mean, Ravi, is it right to say that despite all the recent advances in pharmacological treatment, there is no medical treatment that can replace the virtues of a healthy lifestyle?
No, I mean, I always tell all my patients that it's not a choice of lifestyle or drugs. Lifestyle has to be baked into every management plan. It's a case where the lifestyle is enough. And to be honest, I've seen lifestyle modifications reduce blood pressures by double digits, which is almost as effective as two antihypertensive agents. So it is effective, it is underutilized, but it requires discipline and it requires time from us as clinicians. If you tell patients actually what is required in terms of diet, there's a lot of misconceptions, and critically exercise as well. Exercise is key. You can't just have diet, you can't just have exercise. They've both got to work together.
Fantastic. But having reinforced the importance of a healthy lifestyle, we should, though, I think now have a low threshold for initiating pharmacological treatment in patients with hypertension. We mustn't wait too long before getting that blood pressure down. Even in grade 1 hypertension, a blood pressure just over 135/85, the guidelines, the NICE guidelines, clearly state any evidence of target organ damage, established cardiovascular disease, diabetes, anyone at high cardiovascular risk, or even in patients who are over 80, we should be considering starting therapy. And that is why it's so important to check for target organ damage on our annual hypertension reviews. And this should include checking the urine, checking the bloods. But Ravi, how important is it to do an ECG in patients with hypertension? What in particular should we be looking for?
Well, the key thing on the ECG is evidence of left ventricular hypertrophy. Obviously, we know hypertension underpins other cardiac conditions, as we've already stated. So we have certainly picked up atrial fibrillation coincidentally, and ischemic changes, which may or may not be related to kind of LVH. Then maybe you may actually cover changes that raise the suspicion of underlying coronary disease. So an ECG is absolutely critical.
Great. Ravi, we know patients can have elevated systolic but normal diastolic blood pressures. We see it commonly in elderly patients with their stiffening arteries. Do we treat isolated systolic hypertension with the same vigor and rationale?
No, I mean, for reasons that we've already alluded to, I think these patients, obviously, if you treat systolic blood pressure, you're going to treat diastolic blood pressure as well. And the danger then is you induce hypotensive episodes related to their diastolic pressures. They get dizzy, they fall over, they break hips. So I think you have to personalize the treatment, exercise judgment on an individual basis, and accept that your systolic may not be absolutely perfect, but what you don't want to do is create a bigger problem by over-treating the diastolic.
Great practical tip there. So, well, let's now go to an example of what happens to a heart, in particular the left ventricle, when it's subjected to long-standing, poorly controlled blood pressure. Ravi, can you first orientate us here? This is an echocardiogram of a normal left ventricle. What exactly are we looking at?
Yeah, so you very helpfully labeled it for me. So basically, you've got the heart here. There are 4 chambers: the collecting chambers, the left and the right atrium, and the pumping chambers, the left and the right ventricle. Helpfully, as cardiologists, we have the left on the right and the right on the left. But the key thing to notice is the wall of the left ventricle is thicker than the wall of the right ventricle, which you're not seeing. And this is a kind of a normal wall thickness, anything up to about 10 millimeters. And as well as the heart squeezing, radially, it's also kind of going down, it's moving down forwards and backwards longitudinally. Now, looking to the echo on the right, you'll hopefully spot the difference here. You will notice that in this patient with long-standing hypertension, you've developed left ventricular hypertrophy. The wall of the ventricle is thicker and it's kind of globally thickened. And also the heart's a bit stiffer. And the reason I say that is you're not getting that same longitudinal excursion with every heartbeat that you're seeing in the healthy, normal heart. You're getting kind of, you've lost that ability of the heart to relax. It's stiffened, it's not as supple. But the good news is with treatment of hypertension, you're not stuck with this. If you treat hypertension, your heart this left ventricular hypertrophy can regress and look more like the scan on the left. We've got lovely examples of that in our clinical practice.
Fantastic. The key is to identify this early and get these patients optimally sort of managed in terms of their blood pressure. And moving on to pharmacological therapy, we have an array of effective tools in the toolbox. The British and Irish Hypertension Society have a clear algorithm. ACE inhibitors or ARB should be first line for all patients with diabetes, as these drugs also offer renal protection in diabetic kidney disease. They should also be first line for younger patients under 55 who are not of Black or African Caribbean ethnicity. Otherwise, it's a calcium channel blocker as the first step. You would then combine the two drugs in step 2 and then add a thiazide-like diuretic in step 3. Ravi, most guidelines, including these guidelines and the European Society of Cardiology, very much favor spironolactone, potassium permitting, of course, as a fourth line agent. Is that an option that you like to use?
It on many occasions has made the difference from a patient being untreatable to a patient being completely at target. And I suspect a lot of it is there is a significant proportion of patients who have a degree of hyperaldosteronism, and it often is like a miracle drug. Doesn't work necessarily on everyone, as you already stated. Potassium is potentially a inhibiting factor. You know, by the time you've got on an ACE inhibitor, you may not have enough room to add on spironolactone, but most people will tolerate a small dose. You only need about 25 milligrams for it to have its antihypertensive effect.
And finally, on treatment, a really nice, well-designed study presented at the ESC in 2022, the TIME study, very clearly demonstrated it probably doesn't actually matter in terms of cardiovascular outcomes, whether you take blood pressure medication in the morning or in the evening. So the main message I would give to clinicians in primary care in particular is reinforcing that good compliance of medication. Ravi, can you very briefly touch on this thankfully rare phenomenon of accelerated or malignant hypertension? What are the red flags we should be looking out for in primary care? Because these patients do need urgent medical attention, don't they?
Yeah. So we call hypertension the silent killer. You can have blood pressures chronically elevated at 160, 170 and be totally unaware of it. Really, when you have a patient with markedly elevated blood pressures, so certainly systolics closer to 200, diastolics above 120, with symptoms, and often it's headache, nausea, visual disturbances. This is a medical emergency. These patients need to be seen in an emergency department, need to have expert therapy with initiation of antihypertensives designed to bring down blood pressures in a controlled manner. You don't want to plummet their blood pressures, but it needs to be done in a hospital environment. And then obviously further investigation. The one key question is there a secondary cause? And you worry about things like pheochromocytoma, which are adrenal tumors excreting lots of adrenaline.
And some patients have a sort of more sort of benign secondary cause for their hypertension, often present to us in primary care as resistant hypertension. You know, their blood pressure just simply doesn't come down with sort of first, second, third line therapies. Which patients should we suspect for this and refer on to a specialist like yourself? And very briefly, can you tell us what tests you would do on these patients?
Sure. So these are genuinely the patients who, despite what you've tried, you've been through the guidelines. You know, I think by the time you're on 3 antihypertensives, including a diuretic, if there is no movement on the blood pressure, and the key thing is to establish that the patient is compliant or at least states compliance, it's critical to refer on to secondary care. And we will do some simple things, just specialist bloods, hormones, renin, aldosterone, cortisol, urine collections for kind of metanephrines or catecholamines. We may undertake some imaging. Often you can rule out things like aortic coarctation just by clinical examination, but certainly an echo. We can do something called an MRI hypertension protocol that will look at the adrenal glands and rule out renal artery stenosis, look for LVH, rule out aortic coarctation. But we tend to reserve those in patients who've got bloods or urine markers or other examination features that would raise the suspicion. It's obviously quite an expensive protocol. And the other thing that we can do is just really rigorously assess their compliance by watching them have directly observed treatments, actually getting them into a hypertension unit, giving them their tablets, watching them swallow it, and see what happens to their hypertension.
Great. And I want to now slightly change focus and explore this it's a fairly strong association actually between hypertension and atrial fibrillation. Ravi, this is a very complex slide, but just in simple terms, why are these conditions intrinsically linked?
Well, I mean, hypertension as you follow the kind of flows here, increases your left ventricular stiffness by actually causing diffuse fibrosis. that fibrosis itself causes the heart to remodel. And the key thing here is that as the heart gets stiffer, you raise the pressure in the left atrium. As the pressure in the left atrium raises, because the left atrium is having to contract against a stiffer heart, it enlarges, and that kind of left atrial enlargement results in reentrant arrhythmias, reentrant circuits, which cause atrial fibrillation. So, if we have young patients with atrial fibrillation, I always perform a rigorous assessment of blood pressure, because often they will just have had the isolated blood pressure reading in clinic, which may be normal or slightly elevated.
And atrial fibrillation is actually probably a lot more common than many of us think. According to the ESC, the lifetime risk of developing AF is now in the region of 1 in 3. With the aging of the population and consequent accumulation of comorbidities and risk factors, we're likely to see a significant increase in prevalence over the coming decades. And we know that AF is one of, if not the most potent risk factors for stroke. And so with such a high prevalence and potentially devastating consequences, I think Ravi's made a very robust case that in primary care, we really should be looking for AF, opportunistically screening for AF. I would say particularly in patients with comorbidities like hypertension. And that moves us on very nicely to the next sort of topic. Ravi, I know like me, you really do love embracing and adopting innovation and technology to improve and streamline clinical practice and improvement in patient outcomes. And certainly for me, one of, if not the best innovative technology I've had experience of recently has been the Omron Complete device, which for reasons we've just explained has this almost perfect combination of providing high quality blood pressure readings and at the same time being able to record a high quality single lead ECG and detect those rhythm disturbances like atrial fibrillation without taking up additional time and resource. Ravi, I know you have experience of this technology. What is that experience, and do you recommend it? Would you recommend it to your patients?
Yeah. Absolutely. I mean, Omron is synonymous with blood pressure machines and blood pressure management. It's almost like saying if you say you've got a Hoover, you've got a vacuum cleaner. If you say you've got a blood pressure machine at home, it should be an Omron. And what I've got experience, I've had 2 of these. Simply the first one my father stole off me, so I got a second one. And I use these both in my clinic and for my own monitoring at home. I think all of us need to be aware it's all well and good telling people about high blood pressure, but you've got to make sure that you're also looking after yourself and your family. And this is also fantastic when you have a patient late in the evening, no one else around. You've diagnosed, you've taken their blood pressure, there's an irregular heart rhythm, and you can actually diagnose atrial fibrillation there and then. Have a single lead ECG and be in a position to anticoagulate. So it's the perfect combination. It's the obvious thing to do, and I'm delighted that Omron have had the foresight to create a machine in such an elegant form factor as well.
Yeah, no, I totally agree and endorse those sentiments. And of course, the main concern when patients develop AF is that significant increased risk of stroke. Very briefly, Ravi, explain why this happens, how quickly this stroke risk increases as well would be useful. And to illustrate your answer, we've got an echocardiogram of a patient recently diagnosed with AF. What are we looking at?
So on both panels, you are looking at a mass, which is a clot, and this mass resides in a little outpouching, an embryological outpouching in the left atrium called the left atrial appendage. The reason you're seeing a clot in the left atrial appendage is when you develop atrial fibrillation, the atria cease to contract. They just fibrillate, they just shake around. There's stasis of blood. As you get stasis of blood, you get clots forming, and that clot kind of plops down into the left atrial appendage. The danger is that clot, you can see it's kind of quivering around, could easily dislodge, go through the mitral valve, into the left ventricle, out through the aorta, and into the carotid arteries, subsequently into the middle cerebral artery, causing a massive and life-ending, or worse still, life-changing stroke. And really, it doesn't take very long for these clots to form. There is evidence that clot formation, certainly 48 hours, we get very anxious. But there is some preliminary data clinically say that actually even within 24 hours, your risk of stroke with atrial fibrillation is slightly higher, suggesting that you're at increased risk of clot formation. So this doesn't take weeks or months, this takes days.
scary stuff. And as you say, because these clots tend to block major arteries in the brain, like the middle cerebral artery, you can see here on this slide, causing huge areas of infarction. You can also see the significant sort of midline shift of the brain. I mean, this is catastrophic stuff. And that's why the data clearly show that AF strokes are significantly more devastating than non-AF strokes, associated with a much higher risk of mortality, morbidity, and significant disability. And the biggest tragedy of this all is that we have a highly effective treatment. Anticoagulation is very effective at preventing stroke due to AF. Sadly, 50% of AF strokes occur in people who are not previously diagnosed, reinforcing that importance of proactive detection, particularly in patients over 65 and with comorbidities like hypertension. Ravi, are there any other comorbidities strongly associated with AF we should be mindful of in primary care?
Well, so diabetes, hypertension, coronary disease are the key things. Obviously, you check for thyrotoxicosis, which every now and then will pick up, and clearly just age. As you get older, you're more likely to detect it, and you're more likely to be asymptomatic with it. Young patients tend to present with symptoms.
In fact, this is such an important area that in England, we have a 10-year cardiovascular disease ambition to reduce health inequalities and save lives. And not surprisingly, detecting and managing atrial fibrillation as well as hypertension, together with better cholesterol management, are key priorities. And Ravi, can you please clarify, it causes a lot of sort of confusion in primary care, whether patients with paroxysmal AF, many of which we know are asymptomatic, we see these incidental findings maybe on a monitor, are these patients at increased risk of stroke?
They're at the same risk of stroke as someone with persistent or sustained AF. Having a short burst of AF doesn't mean you're at any less risk at all. You should assume the risk is the same and anticoagulate them as per the CHA2DS2-VASc score.
Great. And I know you're very experienced and familiar with looking at portable ECG tracers, in particular from the AliveCor KardiaMobile devices, which have been around now for many years and are used widely in the NHS. The tracers are very convenient to take. Patients don't have to undress. The device generates a PDF that can be seamlessly uploaded into the patient's electronic records. But the critical question here is, what is your opinion in terms of their accuracy? For instance, are you, as a cardiologist, happy to rule in or rule out atrial fibrillation using this device?
The answer is yes, absolutely. And it allows us, so, late evening clinic, dare I say, I've actually used it in chance encounters socially where a colleague or a relative hasn't felt well. You've used the AliveCor, you've got a clear diagnosis of atrial fibrillation, and you're in a position to start planning anticoagulation, assuming blood tests are available readily. So, we can walk around with stethoscopes. There are some use, but I'd say that actually this is of tremendous use, more so than a stethoscope even.
And of course, this is the very same technology that is integrated within the Omron complete device. And Ravi's views are certainly shared by cardiology guidelines. The ESC now give a class 1 recommendation for the use of single lead ECG traces of 30 seconds or more to establish a diagnosis of atrial fibrillation. The NICE guidelines for atrial fibrillation have now also given the green light for the use of other ECG technology in patients with suspected underlying paroxysmal atrial fibrillation. And in a more recent NICE medical technology guidance, KardiaMobile specifically now has been recommended for the detection of AF. It states the clinical evidence shows a greater diagnostic yield compared to a Holter monitor, and also highly likely to be more cost efficient. Of course, though, innovative clinicians like Ravi didn't have to wait for these guidelines. They've been using this technology in their clinical practice well before these guidelines were published. So KardiaMobile really now is a very well-established diagnostic tool in UK clinical practice. So I get really excited when I see technology develop that can very much help address a very significant unmet clinical need. Technology that can be used routinely in clinic or at home for patients to use, and can really help not just more accurately assess blood pressure, but also win the race in atrial fibrillation. In other words, help us to screen, diagnose, and protect our AF patients before the stroke wins the race, adding years to life as well as life to years. Before we wrap up, let's also mention Omron Connect, which is an app that provides a very slick dashboard for recording all of these data, integrating the ECG traces with a patient's blood pressure, and also able to offer analysis, including a patient's blood pressure average within a specified time period. Ravi, I think this really is the icing on the cake, isn't it, to have the platform as sort of paired with the Omron Complete device.
Yeah, I mean, that's part of the reason that I recommend it to everyone. The Omron Connect app is absolutely exquisite in terms of its aesthetic, but also in terms of the data, the way the data is acquired, analyzed, and things like I just often get a screenshot from patients sending me their average blood pressure using the Omron Connect app. It's so helpful.
Well, Ravi, we've come to the end. I think we've covered all the primary care relevant aspects of modern hypertension management. And in particular, you've clarified what we can and should be doing in primary care, and who and when we should be seeking a specialist assessment. Thank you so much for your wonderful expertise and sharing some real nuggets of practical advice to influence our clinical practice. And thank you all for watching. Goodbye.